oral cavity cancer refer here to the malignant tumor in the oral mucosa and in the tonsil and the oral and the salivary gland. So it mainly affect the older adult, especially males. Patients often present with late with symptoms like pain, difficulty swelling, and the classic presentation is non-healing ulcer. So the epidemiology of the disease is most commonly diagnosed in the people as I mentioned between the age of 55 and 60 years, and especially in the men are affected more than women, mainly due to the higher exposure to the risk factor like smoking and the alcohol. So the risk factor of the oral cancer, tobacco is the most significant risk factor, especially when combined with alcohol, and the poor oral hygiene, also chronic irritation of the oral cavity, and also one of the important viruses here we have the human papilloma virus, especially type 16 and 18. Okay, we have the three type of the precancerous lesion. We have the leukoplakia, we have erythroplakia, and then we have the erythroleukoplakia. When we talk about the leukoplakia, it's the shape is the white patches in the oral cavity. Okay, and the erythroplakia appear red and has a higher risk of the malignancy. Early detection of those lesions is very important. So we have types of the oral cancer. Okay, we have the oral mucosal cancer, is the squamous cell carcinoma. We have also the salivary gland cancer, and we have the tonsillar. The most common type is the squamous cell carcinoma, and the salivary gland tumor are less common but still significant. The tonsillar cancer may be also include lymphoma. So the clinical feature of this cancer, we have the halitosis, and we have a pain, especially behind the ear, and we have a dysphagia, and one of the hallmark symptoms of the oral cancer, non-healing ulcer. Patient may be combined with bad breath, halitosis, and the pain that can radiate to the ear. Okay. Here we have we have an additional signs, oral bleeding, and the facial swelling and paralysis. The bleeding and the paralysis are warning sign of advanced disease. We have a lymphadenopathy, and we have metastasis. Okay, the facial nerve involvement suggests salivary gland tumors. The cancer is spread early to the regional lymph node, and then in the later stage to the distant organs. Okay, we have the diagnosis here. We will start by the diagnosis by biopsy, then band endoscopy, and the human papilloma virus testing and imaging include X-ray, CT, and PET scan. The diagnosis is confirmed by the biopsy and histopathology examination. The image is important for the tumor spread, and the human papilloma virus test is important for the prognosis and the treatment planning. So when we come to the treatment, we have three options. We have the surgery and the radiation therapy and the chemotherapy. Treatment depends on the stage of the tumor, and the early stage of the cancer are usually treated surgically. And the advanced, we can combine the whole three treatment treatment and for the late stage. So we have here the surgical management. The surgical, we have resection plus or minus neck this dissection. Okay, the surgery may be involved remove part of the jaw and the tongue and the oral and the larynx, depend on the tumor location. And the neck dissection is often done to remove affected lymph nodes. So when we talk about the prognosis of the disease, the prognosis is depend on largely on early diagnosis. The human papillomavirus positive cancer tend to it have like a better to treatment and have a better prognosis. So in conclusion, oral cancer is preventable. Reducing risk factor and the early screening can significantly improve the outcome. Awareness is the key to early diagnosis and the successful treatment. So thank you for your attention, guys.
Thank you very much, Dr. Mahasin, for this great, informative, and well-structured presentation. So regarding the second topic, Dr. Nader, it's going to be it's supposed to be with Dr. Isra, but we couldn't reach out to Dr. Isra either through me or through Dr. Marwa. And so I prepared the presentations. If it's okay, outside the agenda, which is systematic review or introduction to systematic review and meta-analysis, and I would like to share it here with the group.
Sounds good. Just give me a second. When matched from the attendees today, because I asked a couple of, I would like to congratulate some of the fellows who matched this year, and I asked some of them to come and share their experience, or if there is any tips or advice. Anyone here? If not, then Dr. Sabry, please go ahead. Thank you so much for your help.
Okay, thank you very much, Dr. Nader. Just I'm going to share my screen. Okay, so this is an introduction to systematic review and meta-analysis, which is kind of the most significant type of research that could be done. Especially, it's not required to get an IRB approval or institutional research board approval for such research. For example, unlike the experimental randomized clinical trials or the cross-sectional studies. So this is an overview of concepts, the steps, and the applications in clinical research. And okay, so the introduction, systematic review, and meta-analysis are essential tools in evidence-based medicine, and they synthesize data from multiple studies to provide comprehensive insights. So if you see the hierarchy of scientific evidence, which is starting from the bottom, in case reports, opinion papers, and letters to the editor, are considered the bottom of the evidence-based medicines in clinical research. And then after that comes the animal trials and in vitro studies, in which the experimental lab studies that are done in the laboratories, and then the cross-sectional studies come afterward, and on top of that, the case control studies and
Sorry
cohort
to interrupt you,
studies.
Dr. Sabry.
Yes.
Sorry, we are still, I think we are seeing the first page or the first slide. I think you are not sharing the presentation slides. If you want to unshare the screen and then share the presentation slide, because they are two different.
Okay.
You are.
Great. Can you see, Dr. Nader, the screen now?
We have the screen, but we have both the slide, the big one, and on the left side, we have the slide number 2, 1, 2, 3, 4. You want us to watch that, or you want us to watch the actual presentation?
Yes, the actual presentation.
So we don't see the actual presentation. Yeah, click on that and see. If you see the presentation, we don't see it. We are
Yes, I'm
still.
seeing it.
So we are seeing the actual slides and the big slide.
Okay, minutes.
So when you share the screen, you can share the whole window instead of a specific program or a specific tab.
Yes. What about now?
It's coming. Yes. Thank you so much. Sorry about that.
No problem. It's okay. Thank you for letting me know. Okay, so regarding the hierarchy of scientific evidence, it's start from the bottom of the pyramids, which start from the case reports, opinions, papers, and letter to the editors. And then on top of that comes the animal trials and in vitro studies, in which these are the experimental studies that are done in laboratory, for example, on rats, and then they will be advanced into randomized clinical trials to be conducted if they are safe enough in human being. And then the cross-sectional studies, for sure. The most common type in undergrad research is the cross-sectional studies because they are easy. And since once you have changed the environment or the populations, it's considered applicable even if someone else do it in, for example, in University A, and you want to take the same idea and apply it to your own University B, then it could be applicable because you change the population. And then after that comes the case control studies, and then the cohort studies, which can be either prospective, in which you are monitoring the patients in future, and then you will measure the change, or retrospective, in which you will monitor the change retrospectively. And then we have the randomized clinical trial or randomized control trials. And there are many subtypes of the randomized control trials. We have quasi one, we have the double blinded randomized clinical trials, and also we have the single arm randomized clinical trials. After that comes the systematic review and meta-analysis, in which the most common type used for the systematic review meta-analysis is preferably to be randomized clinical trials. So if you, for example, want to conduct a systematic review or meta-analysis, let's say, for example, we have a trendy topic on, for example, aortic stenosis valve replacement. And then in the randomized control trials, they just mentioned that, for example, the TAVI, which is transcatheter valve intervention or replacement, is superior to the traditional surgical replacements. So you want to make sure, is this outcome, or is this benefits can be translated into guideline And hence here comes the meta-analysis, in which you are going to accumulate all of the randomized clinical trial, all of the cohort studies that are there in the databases, and then you will do a meta-analysis for them, and then you will publish that. And they are the main area that produce the guideline are the systematic review and meta-analysis. For example, also for sure, the randomized controlled trials can be used for guideline generation. Okay, so the definition of systematic review. Systematic review is a structured, comprehensive synthesis of research studies on a specific topic following a predefined protocol. What do we mean by predefined protocol? It's like the proposal in case of cross-sectional studies, and I believe that most of us are familiar with the cross-sectional studies, in which it's an obligatory and it's a mandatory undergrad research that you're doing in your back in medical school, that you have to submit a proposal either to the IRB or to the principal investigator or your supervisor, in which he will go through the proposal and then either approve it or he might make small minimal changes, and afterwards it can be approved and then translated into the full manuscript. So it's almost the same for systematic review. You have to write a predefined protocols that include mainly the research question or the research title, and then the criteria for inclusion of the studies. And I'm going to explain a lot of this as I'm going forward. And after the criteria, you will have to also define the search strategy that you are going to use in the database, for example, PubMed or Scopus or Web of Science or Cochrane. After that, you have also to write the type of methods you are going to do and the type of analysis that you are planning to conduct. And then you can submit this to Prospero. Now, for Prospero, if anyone is interested to conduct a systematic review meta-analysis, I prefer not to submit the protocol to Prospero unless you are started to writing the manuscript. Why? Because if you just publish it in Prospero and you are early on in your research, then some of the researchers might take your idea and they will go faster than you, and they publish your idea before you even complete your manuscript. So it's better to submit or publish the protocol after you started your manuscript writing. And then after that, we have the steps in conducting systematic review. So the first step is to define the research question. And for the research question, we have the BICO or the BICOs, which is stand for P is for populations. Who are the patients you are going to target? So let us take an example which is going to make the things more clear and easier for us. For example, we want to do systematic review meta-analysis for, as we mentioned, the TAV versus a traditional surgical replacement of aortic valve for elderly patient above 65 years old. So the population will be elderly patients above 65. So this is automatically means that we are excluding the pediatric population, because we are targeting a specific population who are elder than 65. And then the intervention, the type of intervention you are going to examine, which here is the transcatheter valve replacement. And then the comparison is already predefined, which is the traditional surgical replacement of the aortic valve. And then the outcome. For the outcome, we want, for example, to measure the post-hospital comorbidities, for example, the post-surgical or post-operative complications, the mortality rate, the cardiovascular mortality, and also the adverse effect from each type of replacement, either the surgical or the transcatheter. And then the study design that you are going to include in your systematic review, and it's preferably to be all of them randomized clinical trial, but it's okay to include other cohort studies or cross-sectional studies if they if they have the same PICOs. So all of your included study have to be in the same area or the same PICOs, the same populations, the same intervention, the same comparison, the same outcome. But the study design can vary. It's better to be the same one, randomized clinical trial, but it's okay if you include other types. And then the second step is to define the inclusion and exclusion criteria. The inclusion criteria is almost the same as your PICO. It's the same as the research question. The exclusion criteria, anything that cannot be examined or consider an inclusion criteria. For example, if we take the populations, we already mentioned we want elderly patient more than 65. So anyone less than 65 is excluded. So this is considered exclusion criteria. If we move forward to the intervention, it is transcatheter valve replacement. So for example, aortic valve repair will be excluded from this study. And then if we move to the comparison, which is the traditional surgical valve replacement, the exclusion will be also, for example, the repair one. And then the outcome. If we define the outcome as, for example, the postoperative complications, the adverse event, and also all-cause mortality or cardiovascular mortality, so other types of outcome might not be considered. For example, a stroke risk, for example, in these patients, or the risk for pulmonary embolism. So you have to define your inclusion criteria very clearly so that your exclusion will be easy for you to be defined. After that, you have to develop the protocol, and the protocol is pretty much the same. It includes the research question or the research title, and then the inclusion criteria, which is basically the PICO, population, intervention, comparison, and outcome, and study design, and then the exclusion criteria. In addition to that, you have to ask the one who's going to do the meta-analysis or the analysis, the type of the analysis that are going to be done, to be also mentioned in the protocol. And then you have to submit, as we mentioned in the earlier slide, to Prospero. I prefer this to be done while you are writing your manuscript. So you will have, for example, 2 to 3 weeks maximum to submit your paper to either the conference or as abstract to the conference, or a full manuscript to a journal. In the full manuscript also, you have to write literature search, which is known as the search strategy. After the search strategy, then you have to do the study selection and screening. For example, you will go through data bases, for example, PubMed, Web of Science, Cochrane, and you will look for the studies similar to your PICOs, and you're going to extract this study, and you will send them to your research group to do the screening. So the screening, we have two types of screening. First, we have the title and abstract screening, and then the second one, or the second phase of screening, is the full manuscript screening, and it is usually done by at least 2 separate researchers. And the conflict usually either is going to be resolved by a discussion between the 2 researchers who are done with the screening, or by consulting a third neutral researcher or author. Then we have the data extraction, in which we are going to extract all the baseline characteristics of the patient from the research. For example, the patient, for example, the study title, and then the patient age, the patient comorbidities, for example, the interventions that have been done, the comparison or the placebo, the outcome that is measured, and also the study design of that research, the year of publication, and the link to it. This is regarding the baseline characteristic. For the data extraction, it will be different from paper to paper. Usually, it is going to be determined by the first, second, or third author, the one who did the data extraction sheet. Then we have the quality assessment, in which you have to do the quality assessment for the papers that included in your own research or own systematic review, and also the publication bias to be also determined. So the quality assessment can differ according to the type of study that included. For example, if you are including only randomized clinical trial, there are some tools to be used for quality assessment of such study design. And if you are going to include cohort studies, there are also different types of quality assessment tool to be used. And then the data synthesis, which we means the quantitative synthesis or the meta-analysis itself, in which you are going to analyze all your data that are included in the data extraction sheet. And then after that comes the final step, which is not written here, sorry for that, is the manuscript writing, in which you will write the introduction, then you will write the you will write the title, the abstract, and then the introduction. After the introduction, you will write the methods, the results, and then after that, the discussion and the conclusion. This is the Prisma guideline. The Prisma guideline is almost all journal ask you for this Prisma diagram to be submitted with your systematic review meta-analysis, in which you are going to clearly mention all the number of research that you identified through the database screening up to the quantitative synthesis or the meta-analysis. So this is an example. For example, here they identified 807 records identified through the database screening. And then they mentioned what numbers from each database. So here 239 from PubMed, and then after that Embase, and then Scopus, Web of Science, and ScienceDirect. So all of them are databases, and you have to mention clearly how many papers you extracted from that databases, and then how many records have been removed as a duplicate, because there are some papers that will be indexed in PubMed and also, for example, Scopus. So a duplicate paper is considered one paper, so you have to remove one of them, and then you have to mention this as a duplicate. After that, you will screen for title and abstract. So 539 records have been screened for title and abstract. 400 of those 500 excluded because they do not meet the inclusion criteria. So from the starting with the 807, the full text article assist for eligibility are only 74 paper. After that, also after the full text screening, you have to exclude some of them based on the exclusion criteria. So for example, here 39 have no extramedullary plasmacytoma outcome of radiotherapy versus surgery, 16 non-English full text, 4 systematic and other literature reviews, and 3 conference abstract have been excluded. So we are ending only with 12 studies included in qualitative synthesis, and all of these 12 were eligible to be analyzed. So we concluded this meta-analysis with the 12 studies included in the quantitative synthesis, which is the meta-analysis from the start point of 807 records. And then we have the here this is one of the form of the data extraction sheet that we are usually doing in the systematic review meta-analysis, which is known as the summary of the included studies. Usually you have 2 separate sheets that you are going to publish in your paper. One is the summary of the included studies, and the second one is the data itself that have been analyzed. So the summary of included study, for example, here the source of the paper usually it's include the year of publication and the the last name of the first author, and the country of study. Here it's US, Canada, etc. And then the study design. Here the study design were different. So it's okay, as we've mentioned in the first slide, but it's preferably to be the same one to decrease the heterogeneity. So here it's retrospective cohort study, case series, retrospective, etc. And then the sample size in each study, it was 17 here, 5 here, 4. And then the mean age. After that, the sex, how many were female and how many were male, and then the median follow-up duration in each study for the patients, and then the prognostic covariate for radiotherapy versus surgery, and the study quality. So here, the study quality that have been used is the Newcastle, Ottawa. And then moving forward, this is the quality assessment using the Newcastle, Ottawa scale for cohort studies. You will have this study, and then the selection, the comparability, the outcome, and the total score, and then the interpretation. So for these studies, you have to give a star for each categories or subcategories from the selection, each subcategories from comparability, each subcategory for the outcome, if it is applicable. So if you see, for example, the first paper here, it's got 7 star. So interpretation is a good quality. So this paper has a good quality. If you go, for example, here, the Holler et al. 2022, they have 8. So they get a total 8 out of 8 in this type of quality assessment tool, which is Newcastle, Ottawa. So all of the paper here, as a conclusion, have a good quality. And it's very easy for you to use the quality assessment tool because they are like, for example, a checklist. So for example, represent activeness of the exposed cohort, selection of non-exposed cohort, and then demonstration that outcome of interest was not present at the start of a study, comparability of cohort to the basis. So there are different types of categories that are being examined in each one of them. And then after that, we have the meta-analysis. So the definition of meta-analysis, this is the last step that you are going to do before your publication, which is a statistical technique that combines results from multiple studies to drive a bold estimate of effect size. So the statistical method to be used in the meta-analysis, there are a lot of different methods in the meta-analysis, but the most common ones that are being used in the meta-analysis nowadays include fixed effect model, the random effect model, and the heterogeneity assessment. This is the first plot. That is the main point or the main outcome to be used in your paper after the meta-analysis have been done by the analyst or the author who are given this task of analysis. Then it will be written like this: the study or subgroup, and then for example, here the side effect, the weight, and the risk ratio. And usually it has this is the main diagram to be used in the first plot. If it is less than 1, that means it is significant. If that means it is significant. Okay. Advantages and limitation. Advantages: increase the statistical power. It is comprehensive evidence, as we've mentioned in the second slide. It is on top of the hierarchy or the pyramids of the evidence-based medicine. And the limitation include the publication bias and the heterogeneity among studies. Heterogeneities usually comes from either different types of study design or the difference in population, different in interventions, if the included study are not quite the same of people. The application in clinical research, it is usually used to inform the clinical guideline. This is the main outcome for the systematic review and meta-analysis. If the meta-analysis or the analysis itself were very strong, the quality of the included study were very good, then this will definitely go as translated as a clinical guideline. Also, to identify gaps in research. So if you are looking for research ideas and you are struggling to get one, nowadays through AI, you can generate multiple types of research idea, and then you can also proofread them before you move forward. But just in case you are looking for research idea, systematic review meta-analysis is a very good resource to look for the research gap in which you might come up with a new research idea. And then also support decision making, which is the clinical practice. So this is the conclusions. Systematic review and meta-analysis are critical for evidence-based practice, offering robust insight when conducting appropriately. I would recommend this reference, which is the first one, Cochrane Handbook of Systematic Review and Meta-Analysis. And this meta-analysis, which was done and published in 2024, it has a very excellent statistical analysis and a very good quality assessment have been done. It's published in Journal of American Medical Association, which is radiotherapy versus surgery for survival and local regional control of head and neck extramedullary plasmacytoma, systematic review and meta-analysis that you might use as look as going forward with your systematic review meta-analysis to just take the main points. And if you have any questions, please let me know. And thank you very much for your listening.
Thank you so much, Dr. Sabry, for this great presentation and summary for how to do or the basic of systematic review. All right. Any questions or any comments from the audience? So I just want to ask Dr. Sabry, can you share your perspective or your experience when you worked on this project, like from team approach? Like if someone of these fellows now wants to do systematic review to publish in a paper or just as a poster, how did you do it with your team? What task and how you divided it and how you met and so on.
Okay,
Thank
thank
you.
you very much, Dr. Nader. So regarding my experience, honestly, the first paper that I published was the undergrad research, which was cross-sectional studies with the group back in medical school. And then we work very hard to get a good quality paper so we can be able to, as you mentioned, present it in a conference or either to publish it. And alhamdulillah, we were very lucky to publish it. And then after that, I insisted to continue in research because it's boosts the CV for sure and increases the chances for both the clinical and the academic fields. And I reached through LinkedIn to some of the researchers, and I contacted them that I'm very interested in your paper. Most of the time, to be honest, I couldn't get a very good response because I was a beginner of that back then. And then one of the doctors included me because I messaged him through email. So he included me in the team, and then I clearly mentioned that this is my first time to be involved in a systematic review and meta-analysis. He told me it's okay. I will give you a very brief overview, and he did very greatly. And then he gave me the very easy part of the systematic review for beginners, which include the screening and the data extraction. So in the screening, you don't have to have such an experienced systematic review to be able to conduct one. So you will go through a team and then you will just move through the title and abstract of the included studies, and you will look whether the included criteria or the inclusion criteria are here, then you will include this study, or if they are not here, you will exclude that study. Just as simple as that. And then moving forward, he gave me the introduction part for the writing because I wrote the undergrad introduction and discussion. So he gave me the introduction part, and after writing the introductions, now I have a good experience in writing and also in the data extractions and the screening. And then after that, whenever I am looking for a research in systematic review, for example, internal medicine or pediatric, I usually tell the research team leader that I do have experience, and these are the manuscript that I published or the abstract that I presented, and they were very helpful in including me in the research. So usually when you don't have experience, it's very fine for you to start systematic review meta-analysis, and unlike, for example, randomized clinical trials, because there are some steps of the systematic review meta-analysis you will be able to conduct even if you don't have experience. For example, the screening of title and abstract, the full text screening, and also the data extraction, maybe writing the abstract or introduction as well. After you get this information and get this experience, you will be able to move forward and to be sharing more of your experience in data extraction, sheet development, in discussion writing, in analysis. And then also there are two courses that I strongly support for my fellows, which is Writing in the Science by Stanford University. It's a free course in Coursera, and also a course from Johns Hopkins University, also free on Coursera, known as Introduction to Systematic Review and Meta-Analysis. So these two courses, in addition to the Handbook of Cochrane for Systematic Review and Meta-Analysis, will give all of my fellows a great introduction to systematic review meta-analysis. And even if they don't have an experience, but they have the knowledge, they will be able to participate in research teams.
Thank you so much. I ask you because when we graduate from medical school, we see this as a difficult task or unattainable or something that we cannot do. But as you discussed or shared with us, usually these projects divided into small tasks, and some of these tasks can be done by a fresh graduate medical student who just knows how to read, and you give them the criteria and then check which one is meeting this criteria and so on. So it doesn't take you much to participate in a systematic review. You need only to be willing to do a job, and the team leader or the author for that project will give you, as in the case of Dr. Sabry, is given the smallest task or simple task that anyone can do without investing a lot of knowledge skills. And then after taking the first few steps, taking this task, then you will understand what other task in the process, as Dr. Sabri mentioned, this is going through screening, and after screening you want to do review the article, and then after that you will write, and so on. So this may need someone who has some knowledge in the field or some background about the process or what to do with this task. So you're gonna learn that in a stepwise manner. So you start with involving yourself in a project where the people are working on systematic review. If you have no idea, no skills, just mention that you want to start fresh. They will give you a simple task. You're gonna work with them with this simple task, and then you build your skills according to the steps that are needed. And as Dr. Sabri mentioned, also there are few courses. These are free. You can learn about how you can do the whole thing from A to Z. So it's doable for any one of you to start from no background, no idea, to start somewhere and then build your skill to the degree that you can start your own idea from A to Z. You can come up with a research question, you can create a team, and you can divide a task for the team members that under you, and then you can accomplish whatever goal you want. Either you want to publish it as a poster, or if you want to write it as a paper as well. Does it make sense for you guys? Or Sabri, Dr. Sabri, what do you think? Thank you.
Thank you very much, Dr. Nader. You just explained what I mean very clearly. It's always start with one step and small steps, and then you will make from this one small step 1 meter, and then after 1 meter, you will make 100 meter, and then 1,000 or 1 kilo. So even if you don't have experience, I would suggest, as Dr. Nader mentioned, to start with get yourself in the research field with the background or the essential introduction from these courses and the handbook of Cochrane. Even if you just go through them, you don't have to study them very well. Just go through them as the first look, know what is there in the science, and then you can go for this essential step, as Dr. Nader mentioned, the smaller steps that you don't, you are not going to be asked to have an experience for. For example, the inclusion criteria, as Dr. Nader mentioned, it will be already here or given by the first author, and you're going just to check for the title and abstract if they are applicable or not. If they are yes, you're going to include them, and so on. So after that, or even if you would like to start with only the review articles, it's also very easy and has a good publication acceptance or acceptance rate. The review article, the cross-sectional studies also as well. So all types of research other than randomized clinical trials can be done as a beginner, even the systematic review meta-analysis. The RCT that are somehow need some experience and some of the effort, but systematic review meta-analysis, especially, what do I like about it? It doesn't need any approval. So from your own laptop, from your own room or your own hospital, you can just open your laptop and start working on it. If you start small, then inshallah, after 1 year, you will find yourself published 2, 3, even 4. And then after that, you can start, as Dr. Nader mentioned, your own research project, starting as a first author. And later on, you will be mentoring your fellows or your junior fellows. So you will be the principal investigator or you will be the supervisor. So even more and more experience. And this will open for you a lot of doors, either through matching or through jobs, because anything you've provided for the good for patients, it will come back to you definitely. So starting with the small steps, starting with the courses, starting with the insisting for showing your proactivity, showing your interest, you're passionate about research, definitely you will get a spot in a research team, and then you can move forward, inshallah.
Thank you so much, Dr. Sabry. Any questions? So I'm gonna share my experience with you guys. So when I finished medical school, I came here. Research was not like the greatest skill that I have. I did during medical school. I know how to obtain the data, how to use a computer at that time, generate graphs, get references, but how to write, how to approach conferences, how to complete a task, like writing a case and present it in a conference or a meeting. I have no idea about the process. So I did my first year in training in residency in New Jersey, and it wasn't required. So we just clinically oriented. So we see patients, you learn and you take tests and prepare for the board, something like clinically only approach. When I moved from New Jersey to Michigan, I found myself in a group where most of my colleagues were working on papers or abstracts and doing a lot of research work. And I'm like, oh, I'm really behind. So I was lucky to see one patient that for me, it was a unique presentation. So here in Michigan or MSU, they have an annual meeting for residents where anyone can present their cases or their posters or their let's say, abstract, for example. And they start from medical school. They present during their school years. And when they are resident, they present their posters about topics or about cases and so on. So I was a senior. I wanted to present that case, but I didn't know how to. So what I did look at previous presentations, previous posters, previous abstracts in the literature, and I did it like anatomy. So I dissect what they want to present in a case. So they want to have a background and to have an importance of why this topic is worthy of publishing or worthy of sharing with others. So you have to read about what's in the literature and what are you bringing to the literature if it's something new. In other cases, maybe it's a unique that it's a rare case. So you want to see how many rare cases in the United States, for example, or the work that was published, something like that. So you need to know how to approach your work to be acceptable in a conference. In my case, it's only a case presentation, so it did not take a long time. I just was lucky to know few steps that I need to do. I need the case. I already have that. I need to have a background about the case, and then I need to show the importance of why this is need to be shared with others. Because in the medical field, when I know something, for example, clinically, patient come with fever, cough, I should suspect pneumonia, for example. So this is in the literature. So this is why you think about your work, and then when they review your work, there is a chance of acceptance. So you think about what's important for the reviewer. So for my case, it was a rare, unique case, and I have the background, I have the importance of that. So I did it my second year, and I was lucky. So by the third year, now I know the process of presenting cases, and I have my juniors, students or residents. So I know which case I can pinpoint. I can say this case is unique, and we can review the literature, see if it's truly unique. So I ask them to review the literature, and if they agree, then we will present that case. So they have to put the case in a presentable way and the importance, and then put it in an abstract and submit it. And we have a couple of cases presented for my junior. So this is my experience as far as research from my side. I worked in a different environment before I started residency. I worked in an MRI center where patients with MS will come and they take their scans, MRI scans, and they studied this, and then the director will publish this according to different style, different analysis, and so on. So my job was data manager. Basically, I collect the data, I put it in a spreadsheet, make sure the quality of that spreadsheet is accurate, and then give it to them. And then there is an analysis done by a statistician, and then whoever attending in that group, they will write the introduction and so on. So for me, I was just seeing what they do, but I didn't participate as much apart from collecting the data. When we started this program, I didn't have any knowledge about systematic review. So the first group, we work on data analysis. So we collected data from the hospital, all the typical way of reviewing the chart, collecting the data, analyzing the data, and then present it in a way to a conference. And we were lucky to have the data available during COVID, and we presented a couple of abstracts out of this data in 2 conferences. So the first student or fellows in this program, they were able to work with statistician to get some results out and analyze it and submit it to conferences. After that, the second or third batch of this group, one of them knew how to do the systematic review. So he taught or she taught some of the other fellows. And by the second year, third year, we have a lot of systematic review abstract. These were submitted to different conferences, and maybe some abstract manuscript. They were also submitted to journals. So we were successful. And from that, I learned how to show you guys or share with you the steps and how to do it. The last point I want to share with you is a few years ago, I wrote along with my team, a paper in one of the journal about the technology. So my interest focused in technology in older adults, and we were able to work on that. And I was the main author or the key player, where I divide the task and I collected, make sure they are on time, and then submit it, and then get the review feedback, and then reply to them, and finally it was published. So I learned the whole process from writing to publishing in that article. And I work with very good members in that team, where I learned how to organize your thoughts, because it's one thing that you have a data, and it's another thing when you present this data in a meaningful way to the journal or to the conference reviewer, because they want to see certain things. The introduction, for example, you tackle a question, but you don't go to the question right away. You want to give a little bit background of what you're going to talk about, something like that. If that makes sense to you guys. But I hope this will inspire some of you to work on getting the skills just one task at a time. So you can start off with a question. If you don't have a question, you can work with a group that's working in, for example, a systematic review. Just join and say to the leader, I want to handle one task. Maybe just as Dr. Sabry shared, only do the screening, only do this part, only do this part. In the meantime, you can learn how to work with the team, and then you're going to learn the other skills. And in no time, you will have an idea from A to Z, how to start from the question until you publish it, if that makes sense. Thank you so much. And if no more questions, we can go to the next topic.
Thank you very much, Dr. Nader. You are really big inspirations to me personally, and I believe to most, if not all, of the fellow colleagues. Thank you very much for sharing us your experience. And for the last presentation, Dr. Nader, can I present the aortic stenosis? Which it's
Yes.
not in the agenda.
Yes. Yeah. Go ahead. Thank
Okay.
you so much. Thanks
Thank
for
you.
your kind words. Yeah, thank
No
you.
problem. Okay. So Today I'm going also to talk about the valvular heart disease, aortic stenosis. So obviously we are in a geriatric fellowship. Aortic stenosis is very common among geriatric patients, and I do like the cardiovascular systems. That's why I prepared this presentation. So the aortic stenosis, we are going to discuss the etiology, the physical examination finding, how to assess the severity of a patient with aortic stenosis, and how would be the natural history of such patient. What are the prognosis for the patient with aortic stenosis if they do not underwent or undergo the replacement, and what is the timing of surgery? So the common clinical scenarios is either going to be a younger people or an older people. So our focus is usually with the older people, since the aortic stenosis is very common in older patients. But in general, the younger people can present with functional murmur, which is innocent murmur in pediatric. They can present with mitral valve prolapse, and I believe it's very common in the West, in the United States and Europe. And also bicuspid aortic valve, which is considered the most common type of the most common cause of aortic stenosis in younger people. And then in elderly patients, aortic stenosis versus aortic stenosis. It's usually aortic stenosis in these people. The innocent murmurs are common in asymptomatic adults. It's mainly of pediatric murmur, but it can present in adult as asymptomatic murmur. It's characterized by grade 1 to 2 and usually at the left sternal border, and it's usually systolic ejection pattern. So my method to pick this on the postgraduate exam or the clinical practice is to remember that if the murmur is diastolic, and if it is holosystolic or pansystolic, it is usually pathological. The only type of murmur that can be onset or functional is the systolic murmur. But the diastolic or the pansystolic murmur, which present throughout the systolic cycle, this is usually a pathological murmur. So this is the pattern of the innocent murmur. It is usually systolic ejection murmur, which is resembling the murmur of the aortic stenosis. If you see the diagram, it is crescendo, so increasing in intensity, and then decrescendo, decreasing in intensity toward the diastole. So it is normal in intensity with a splitting of a second sound. And then no other abnormal sound or murmur can be heard on auscultation, no evidence of left ventricular hypertrophy, and no increase with Valsalva strain phase. So here an example for elderly patient. He is an 83-year-old man with exertional dyspnea. He is previously well, and now he has a gradual onset class 2 dyspnea with occasional lightheadedness with exertion. And on examination, we found that he has a grade 2 ejection murmur. So this case most likely to be aortic stenosis because the patient is symptomatic, 1. 2, he is elderly. 3, the patients have the classical ejection murmur of aortic stenosis. So is there a significant valvular heart disease in such a patient? Yes, it is aortic stenosis. Which valve? As we've mentioned, the aorta. Is the valve playing a role in this dyspnea? Yes, because the aortic stenosis main pathophysiology is that the patient have obstruction to the left ventricular outflow tract. So these obstructions result in the shortness of breath with increasing the heart work or increasing demand, result in cardiogenic syncope due to decreasing the blood supply to the brain, and also resulting in chest pain due to decreasing the blood supply on demand. How do you distinguish aortic valve sclerosis from stenosis? This is usually done by echocardiography. What are the clinical signs of severe aortic stenosis? We are going to know in the next few slides. What tests are appropriate? Usually for these patients, we consider echocardiograph, either transthoracic echo. Usually we will start with transthoracic echo, and if the patient is going to undergo a surgery or replacement, they might go transesophageal echo and ECG. Maybe also the cardiac catheterizations for predicting the coronary artery disease. When the surgery is indicated, it's depending on the symptoms and the area of the aortic valve. So what are the symptoms for aortic stenosis? We have the cardinal symptom, which is usually taught to us in the medical school as the SAD, which is syncope, angina, and dyspnea. These are the classical triad for the aortic stenosis. The patient might have other symptoms of heart failure later on if the disease is severe enough. For example, heart failure of the symptoms of left-sided heart failure, and then it can result in right-sided heart failure as well, which is combined as congestive heart failure. So the patient may have, for example, nocturnal dyspnea or paroxysmal nocturnal dyspnea, orthopnea, dyspnea on exertions, bibasilar crackles on lung auscultations, lower limb edema, etc. So the chest pain or angina due to reduced coronary flow reserve, increased demand, high afterload. So the chest pain is usually due to decrease the supply while there is increase in the demand. The syncope is the same. The syncope is the same as the pathophysiology of the chest pain, but because of decrease the blood supply not to the heart, to the brain. So the patient might have syncope. So for this patient, usually we do echocardiograph, and it's very important for you to differentiate between the cardiogenic syncope and the other type of syncope, which might include vasovagal syncope, the orthostatic syncope, and or neurogenic syncope, for example. And then we have the dyspnea on exertion and rest, impaired exercise tolerance, other signs of left ventricular failure, diastolic and systolic dysfunctions, which is known combined as congestive heart failure. So common murmur and timing, we can differentiate between these type of murmur. First, we have the aortic stenosis, which is crescendo, decrescendo, systolic ejection murmur. We have the mitral regurgitation murmur, which is pan-systolic. It's present throughout the systole from S1 to S2. We have also the mitral valve prolapse, which is systolic click. And we have tricuspid insufficiency. It is the same of mitral regurgitation, but it increases with inspirations. And also, of course, the auscultation area is different because the mitral regurgitation will present on axilla and will be radiating, present on the apex and will be radiating toward the axilla, and the tricuspid will be in the tricuspid area. The diastolic murmur, we have the aortic insufficiency, which is decrescendo diastolic murmur, and mitral stenosis, which is opening snap with diastolic rumbling murmur. Okay, so the physical findings, we can have either mild to moderate type, we can have the mild to moderate type or severe type. So the mild to moderate will be crescendo, decrescendo. So increasing in intensity in the systole and then decreasing in intensity. While in severe, it is usually crescendo taking most of the systole and then decrescendo toward the end of the systole. So intensity does not predict severity. This is very important. Presence of thrill does not predict severity as well. And decreased or delay and prolongation of pulse amplitude. Paradoxical S2 will be present because of the delay closure of aortic valve. S4 might be present with left ventricular hypertrophy, and S3 with left ventricular failure, and S3 will be present directly after the S2, while S4 will be just before S1. And the difference between them is that S3 usually present with aortic regurgitation or mitral regurgitation, in which the patient have it is the sound of blood reverberations in the dilated ventricles, while the S4, it is due to blood hitting the stiff ventricles in case of aortic stenosis. So this is the correlation with the finding in correlation with severity in case of aortic stenosis. Carotid delay, yes, it might correlate with severity. There is a carotid delay. JVP prominent A wave, it's not correlated with severity. A2 audible over carotid. If A2 transmitted to carotid means aortic valve gradient is less than 50 millimeter mercury and stenosis is not severe. Apex sustained atrial kick or enlarged or displaced apex, it is associated with severity. Thrill has nothing to do with severity. Cardiomegaly and clinical or just X-ray finding of heart failure associated with severity. Soft S1, paradoxical S2, S3, and S4, all of these findings correlate with severity. While ECG, if there is left atrial enlargement or left ventricular hypertrophy, also correlate with severity. So this is an ECG of that man that we've mentioned in the previous slide. It shows left ventricular hypertrophy, which is showing the left bundle branch block and left axis deviation. So for the aortic stenosis, usually in younger patients, we will think in congenital such as bicuspid aortic valve. This is 2% of populations have the bicuspid aortic valve. So these patients are at risk to develop a premature aortic stenosis before their 60s or 50s. And it is a ratio of 3 to 1. So the male are more affected than female, with coexisting coarctations of aorta in about 6%. So 6% of those 2% with bicuspid aortic valve will have a coexisting coarctation of aorta. Rarely, they might have unicuspid aortic valve, subaortic stenosis, and in case of middle-aged patients, we think of bicuspid or rheumatic heart disease. We know that rheumatic heart disease mainly affect the mitral valve, which is acutely present with mitral regurgitation and later on present with mitral stenosis. However, it can also affect the aortic stenosis, the aortic valve. Old patients think degenerative, which is this is the most common type of aortic stenosis that we encounter in hospital in elderly patients due to valve degeneration. So congenital bicuspid valve is the most common abnormality in younger patients. Rheumatic heart disease and degeneration with calcification are found as well, but these are more common in elderly patients. If you see this figure, the left is the normal aortic valve, which is tricuspid. Here, this is the bicuspid aortic valve in which these patients have already stenosis, if you can appreciate, because this is increases the risk as we discussed. Here is a normal geriatric calcific valve that is going to develop into aortic stenosis. This is also a bicuspid aortic valve. This is the normal one, and these two ones have already stenosed. So the etiology of aortic stenosis is really dependent on the age group. If they are young, the most common cause is bicuspid aortic valve, which is a congenital finding. And then 25% will be post-inflammatory and 18% degenerative. The other 7% are miscellaneous. While in elderly patients, the most common cause is degenerative valve, followed by bicuspid valve, and then post-inflammatory phase. So the normal aortic valve area is 2.5 to 3.5. The mild stenosis is considered 1.5 to 2.5 centimeter square. And the severe stenosis is less than 1, in which these people are at risk of heart failure and further hospitalizations and ICU admission. So these patients are a candidate for replacement. So this are the echocardiograph or echocardiogram finding. We are going to look for the valve gradient and area, if there is any left ventricular hypertrophy, systolic left ventricular function, diastolic function, left atrial size, concomitant regional wall motion abnormalities, and coarctation associated with bicuspid aortic valve. So the prognosis is very excellent with replacement. However, if the patients refused to undergo surgery or there were a lot of comorbidities and contraindication to underwent replacements. So nowadays we do have the TAVI, which is transcatheter aortic valve intervention or replacement, which is done either through the radial artery in the arm or the femoral artery in the thigh. So it's quite easy and accessible to most of the patients with aortic stenosis to undergo replacement nowadays. But if they are unable or there are some reasons they did not underwent the intervention or replacement, the outcome or prognosis is very poor, especially if they do have the symptoms of SAD, which is the angina, syncope, and congestive heart failure. So the valve replacement for severe aortic stenosis, operative mortality, elderly patients, it is 4 to 24% if there is morbidity, and 3 to 11% in asymptomatic severe aortic stenosis. If the patients have a heart failure and they were unable to undergo the surgery, the life expectancy will decrease very significantly. So the risk factor for the operative mortality, there are some factors that we have to consider before sending the patient for surgery, is the functional class of the aortic stenosis, lack of sinus rhythm. For example, if the patient have atrial fibrillation or supraventricular tachycardias, if the patient have uncontrolled hypertension or pre-existing left ventricular dysfunction or left-sided heart failure, if they have a coexisting aortic regurgitation or concomitant surgical procedure. For example, they are going to have a CABG in the same surgery, previous surgical bypass or emergency surgery, for example, aortic dissection repair, or if they are female. These are the type of the prosthetic heart valve that are used, and there are a lot of other new types that are used in the transcatheter replacements. This is the cased ball valve. This is the disc valve. This is the bioprosthetic valve. And that concludes our presentation. Thank you very much.
Thank you so much, Dr. Sabry. And this is a great topic. I mean, it's an important topic. And you're going to see a lot of patients with this condition. And you need to know, as mentioned here, how to find out what's going on with your patients, how to diagnose, and also what options of management as far as how you can help your patients. So TAVR is one of the procedures that's less invasive compared to the surgery, open heart surgery, and there are indications for each. And there are a lot of literature in both areas. So I'm going to just share with you my screen here. So this is how the procedure is done. Basically, start it from the beginning. Okay, basically, as Dr. Sabry mentioned, you're gonna go inside. It's gonna start again from either the arm or the leg femoral area. You're gonna go inside, and then there is a period where they want to stop the heart, or and then you want to insert or implant the device. And this is how it's done. I have a couple of patients who has done this, and their quality of life improved significantly after the procedure. So you can search it either TAVR or TAVI implantation. It's a neat procedure. One thing I wanted to share also with you is in medical school, we used to learn how to do the physical examination. And as Dr. Sabry mentioned, you take the history. If you have good history, you know what exactly you want to do in your exam. In this case, you want to listen if there is murmur. In some situation, the murmur might not be easily heard. So one thing I used to teach my students here at the medical school or the residents when we round on patients, if you want to listen to a murmur, you want to find out if it's systolic or diastolic. And one easier way to do that is to check the pulse while you are listening to the murmur. So the pulse, you find out if there is S1, S2, and if you find S1, S2, then you identify the murmur. Is it between them or is it after S2? And with the pulse, is it with the pulse when you feel the pulse or is it after the pulse? And that's a little bit of trick about how you can identify which murmur you are listening to. And some of them might be just physiologic, with a thyroid condition, with fever, with pregnant women or in children, as Dr. Sabry mentioned. So if it's a systolic and you don't think it's causing problems, then you already identify the source or the problem of the patient. That's you can reassure them. If it's diastolic or if it has certain qualities, as mentioned earlier, then you will think, oh, what valve involved and what could be the problem with the valve. Is it stenosis or is it regurgitation or is it both? Sometimes you might have a murmur that has both qualities like systolic and diastolic. Just I want to make sure you understand if you see your patients, and it's a fancy area. As Dr. Sabry mentioned, it's interesting. Thank you, sir, Dr. Sabry, for sharing this important topic.
Thank you very much, Dr. Nader, and also for your showing us the illustration. It's very great. And thank you for sharing your tips and tricks in identifying the systolic and diastolic murmurs as well. We've concluded today's agenda. If anyone's have any questions or any comments.
Thank you, Dr. Sabry, and the presenters, Dr. Mahasin. And if you have any questions for the presenters, please interrupt us. The next part will be an update. If you have any updates of your projects, if you have questions or any need help with anything, let us know. I'd like to congratulate the fellows who matched this year. And one of the questions they shared with me is when they asked them about the fellowship, what kind of involvement. So most of the time they will say, I was involved in a research project. And the question will be followed by that is, what did you do? So my suggestion to those who will answer this question is to start with the team rather than yourself. So you will start with, my team and I worked on this topic or this article or this whatever systematic review, and we divided the task. So my part in the project was, and then you can talk about your part. So highlight the role of a team. So it's showing that you are a team member, you work with other team. If you are a team leader, then you will highlight your job as a team leader. You divided the task and then you follow up with the fellows in your team and make sure that every task was met by the deadline and so on. Then you can elaborate on the area where what kind of task you did, or what the topic, or what did you find, and what the end result, what article you published at, and how the process, or what conference, if you presented at a conference, and so on. So just to keep that in mind in the future, hopefully you will be involved in some of the research project, and your part will be easy for you to discuss and share and highlight what you do. I have a couple of announcements. So one of the things that in this program that we are very lucky to have you guys and others who went through this program. So we have significant number of fellows from this batch. They match to residency program, and the number this year is 84 fellows, and last year was 71. So we have a significant increase in the matching program, which is good, alhamdulillah. So I hope for those who did not match this year, they can work and get a good chance next year, and we'll hear good news about them, inshallah. There are a few openings that will open until June, July. So for those who are in the US, I think it's better for you to contact some of these programs, see if there is any unseen open positions. Sometimes they will need someone who is ready to start by July 1st. So for those who have passed the steps, who have the ESFG and any experience here, and no issues with the visa, then you will be able to hopefully fill some of these unforeseen openings. The other way around is if you did not take step 3, I'd highly encourage you to take step 3. If you have some experience from outside, clinical experience, or in the US, and you have step 3, if you have green card or citizenship, you can apply to some of the fellowship programs, including geriatric medicine, infectious disease, or nephrology. And we have some success in the past with some of the fellows here who matched or who filled some of the gaps in these fellowship programs, and they were successful in completing the 1 year in this fellowship, and some of them went back to residency, and it's easier for them to go to a second year, and, or even if you want like to start from first year in a specialty that you want to, it's easier if you have already have completed a fellowship. Some will do extended fellowship. One of them, for example, he did nephrology, and after nephrology, he did a fellowship in transplant, kidney transplant. So there are openings also there. So these are some of the things that hopefully you will think about. If you are outside the US, unfortunately, the ban will affect you. If you have citizenship, that's I think might elevate things or improve it if you have green card. But if you need the visa and the other process, I'm sorry for what's happening nowadays. So if you think about improving your skills, going to training in other places in Saudi Arabia, in the Gulf area, in UK, Ireland, any place else, we will be happy to help you if you need letter of recommendations, any type of support. We'll be happy to help you with that. If you want to participate with like or learn more or get a master degree and so on, that also will help you down the road, inshallah. Any questions about the fellowship here? Any suggestions, any ideas?
I have a question, Dr. Nader,
Yes, go ahead.
about the fellowship. So, how can we apply for the fellowship and where exactly? Or if we have like the just
So
the
the
guide.
best,
Yeah.
the best thing is to what the fellows did in the past is contact fellows who match to these programs. So which area you are interested in. If you are interested in geriatric medicine, for example, we have a couple of fellows who match to geriatric medicine fellowship in Chicago, in other places, and you can ask about what they did as far as the process. I know not all fellowships accept that route. Like most of the fellowships, they want you to finish either internal medicine, the 3 years, or family medicine, and then you go for fellowship. But there are some programs that are allowing international medical graduates to be accepted without US training, like residency. They just want you to have some background back home or overseas, maybe 2 years or something like that of training. Did I answer your question?
Yes, thank you. Do you have any idea who will accept for follow-up in like infectious disease?
If you send me an email, I'll forward to so some fellows we can try to.
Okay, I will send you email.
But,
Okay,
yeah.
Thank you. Thank you so
I
much.
have a list of fellows who match to infectious disease, nephrology, geriatric, and so on, but I'll give you their contact info.
Okay, thank you.
You're welcome. Any other questions or any other comments or any other suggestions, new ideas, new projects?
السلام عليكم دكتور نادر.
عليكم السلام ورحمة الله دكتور داليا.
الله يعطيك العافية. And I just have a question, where to find the WhatsApp group number?
The big
That's
WhatsApp.
just my question.
Sure. So anyone can share with Dr. Dalia in the chat, maybe. Or if you put your phone number, Dr. Dalia, in the chat, maybe someone can add you to the.
Okay, sure.
Yeah.
Thank you.
Thank you. So if you don't have a project in mind, or if you are interested in doing a project and you want to be participating as a team member, I have an idea and I'd like someone to start and maybe some to join the team. So my idea is we're gonna, let me share the screen with you guys and then I will explain what I'm saying. So here's my idea. So basically, we can work to get an abstract out of this idea or a paper out of this idea or maybe a new mobile app out of this idea. The process to do that is to think about patients with COPD or patient with asthma or any area that of interest for you. But for me, I want you to focus on one thing and you can apply the same concept to any other disease. What you're gonna do is you're gonna ask the question, what's going on? For example, you want to do a systematic review, for example, as Dr. Sabry showed us how to do the steps. So you're gonna come up with a research question. about the mobile apps that are used in patients with asthma or patients with COPD, and you can specify more on that. If there are a lot of them, then you can particularly specify more questions out of this. If there are written studies, written papers about the topic, that would be great. You can do a systematic review and see. If there are none or if there are few, then you can identify areas where you can contribute, or what we call the gap, the research gap. The other way to do it is, so for that you want to do a literature review. You want to go to PubMed or Cochrane and see if there are articles in the literature. If, let's say, you want to go for mobile application development, then you will go to the app stores, either Apple App or Store or Google Store, and see how many apps are there for patients with COPD, for example. And you're going to identify, let's say there are 10 here or 20 here or something like that. What you're going to do is you're going to build your team and divide the tasks. So one of the tasks is to look at these apps and see how frequently are these downloaded, the usage, and if there are feedback. Usually there are some either positive feedback or negative. If they are negative, what the users find out, what's the problem with the app. Or if there are features that they request. Let's say the app collect certain data, but they want to collect additional data. For example, the app might ask only for how many breathing treatment you take or how many episodes of shortness of breath, but they don't take into consideration collecting the use of the medication, what medication list, and the user wants to add the medication or edit the medication and so on. So this is a feature that's not mentioned in the app, something like that. So if you have a team, you can say, team, we want to work on Google Play Store. You identify how many apps, and then you do it similar to the systematic review. You look at each mobile app and divide your team to check if you have positive, negative, and see what's the possibility for you to compare of this app in these two stores. And the next step will be, after you collect all this data, to come up with either a poster saying that we found this number of data, a mobile app. The users, mostly they say it's positive, or most of the users says this, that, whatever you find, and then you publish it in a poster and abstract. Or you can do a whole systematic review, for example, about the use of mobile application in patients with asthma or patients with COPD, and what you found that most of the apps do this, but the users find out this, and these are the features that the users will need, and physician perspective, whatever, EMR and so on. Or the last part is you want to develop your own mobile application, and with this new AI available, then you have a tool where you will say, I want you to build me an app for patients with asthma, and then if you have the features that are missing in the market, then you will say, I want the app to be user-friendly, and the features are 1, 2, 3. And then the AI app or the AI tool will develop demo for you, or a web page, or some kind of an app, and then you can improve that. And eventually, if you are happy with the app, that app can be uploaded or shared in the Google Store or Apple Store in the future. And this was done by some of the fellows in this program in the past. The dental group worked with some developers. This is before AI. They developed an app that was published in Apple Store, and there are other fellows who worked with also different. Some of them they developed their own app, but they were able to publish them in the Google Store. I think 4 of them or 5 mobile applications were published there in the past few years. So you can do it. It depends on how much time you have or how much interest you have. But let me know. I'm gonna share with you the screen here. So let's see, share. So if you are interested, you can put your name in the team here. You can put your name as a, let's say, I'm gonna put it in the chat. So you want to add your name, you want to add your email and the role, if you want to be leader or team notes or team member, or if you want to be leading author, for example, if you want to apply to submitting author. So any role you think about, so you can just put your name and put the role you want to, and then you can assign between you who will be leading the team if there is a leader, what the task they want to do. And here are the basics of what we just discussed about how do you do it. If you have questions, you can let me know and we can handle them. I hope that makes sense for you guys, and if you have interest, please add your names and we'll take it from there. Any questions or any comments? And even if you are new, the process is the same. For example, this one, if you are new to the fellowship, welcome to the program. The step is to be in a team. In this idea or this project, you will be a team member in the team, and then one of the team members will be acting as a team leader. So the team leader basically organizes stuff. So they will say, let's do this, who is available? Then whoever available will do it. And the basic steps are simple. So step number 1, if we want to look at the store, some of you will go to Apple Store and then look up COPD, for example, or chronic obstructive disease or whatever, and then see how many, and then you collect this and put them with their data in one sheet. And then someone else might go to the next step where we want to look at the feedback from the users. How many users says positive, how many users says negative, how many users ask for features, what are these features requested, for example. The third group, maybe they will use AI. So in my case, what I try to do this myself. So I used AI to compare the available mobile application used for patients with COPD, and it pulled some of these, and I have a table where each one is compared to the other. And then you can see if you want to pinpoint more additional question from that. So you don't need a very good background in research to do that. It's just the tool is there. You can ask any question. The AI will help you. But the basic thing is to look up what's in the store and collect any information that you want to collect. A simple thing is how many users for each app. So app number 1, 2 million. App number 2, 10 million. App number 3, 200 million. So app number 3 is very useful for patients. This is why it's very common, if that makes sense for you guys. Thank you. Any questions, any other comments, or just you want to share your thoughts? So if you want to do a systematic review, Dr. Sabry, would you be able to help anyone who wants to go that route, for example?
Yes, sure, Dr. Nader. Sure, I would be happy to help. I will send here my phone number as well as my email, and anyone interested to continue with the Dr. Nader idea in systematic review, please reach out. We can work together.
Thank you so much, Dr. Sabry.
Sorry, this email is not working anymore. I'm going to delete it just to prevent any confusion. So this is the new email. And this is the WhatsApp number.
Thank you so much, Dr. Sabry.
Yes, it's my pleasure.
So if no more questions, I'd like to thank you all for attending this meeting. Thank you all for your time and your effort and willingness to participate in this program. Thank you, Dr. Sabry, and thank you, Dr. Mahasin, for great presentation and sharing your effort as well. And I'd like to thank those who will come to watch the recording in the future. Assalamu alaikum. We'll see you next week. If you have any questions, please reach out. And if you have any comment, Dr. Sabry, go ahead. Thank you.
Thank you very much, Dr. Nader. Thank you, Dr. Mahasin, for your great presentation. Thank you, dear fellows, for your kind words and comments. And please, if you do have any concerns or any comments, any questions, or you want any assistance in your research, please reach out. Thank you very much.
Thank you.
Thank you so much, everyone. Have a wonderful day or have a wonderful night. Assalamu alaikum.
Assalamu alaikum. Thank you so much, Dr. Nader.
You're welcome, Dr. Wala. Have a wonderful day.
السلام عليكم شكرا دكتور نادر
تسلم يا سيدي. عليكم السلام ورحمة الله.
Assalamu alaikum, Dr. Nader. Thank you so much. It's very
You're welcome.
useful. Thank you.
Thank you so much for joining. Yeah.
Mhm.